On this episode of WarDocs, Army Colonel Dr. Aaron C. Pitney shares his journey into military medicine, discussing his inspirations, challenges, and experiences in pediatric hematology-oncology and diverse roles in military medicine leadership. He reflects on impactful patient cases, the transition from clinical roles to leadership, and the mission of the U.S. Army Medical Research Institute of Infectious Diseases, USAMRIID, in protecting against biological threats. Dr. Pitney discusses the rigorous safety protocols and procedures involved in working with a BSL-4 containment facility, the challenges faced in military research, and the importance of collaboration between military and civilian sectors during public health emergencies like COVID-19. For further information about Colonel Pitney and our previous guests, visit our website at wardocspodcast.com. Be sure to follow WarDocs on your preferred podcast platform and subscribe to our WarDocs YouTube channel. I'm your host, Dr. Doug Soderdahl, retired Army urologist.
Welcome to WarDocs, the military medicine podcast. This show brings you a first-hand, behind-the-scenes look into the mission, unique opportunities, and deployed experiences of the entire military healthcare team. From state-of-the-art hospitals in the United States to the most austere environments across the globe, WarDocs has you covered.
Today, we're privileged to welcome Army Colonel Dr. Aaron C. Pitney to WarDocs. Aaron, thanks for joining us today.
Hey, thanks a lot, Doug. It's really great to join you. I know we've talked about this for a while, and I'm glad we're able to finally link up and make it happen.
Yeah, so you graduated from West Point, and then you attended the Uniformed Services University of the Health Sciences. What led you down the pathway into military medicine?
I was thinking about that, and I would just go back to kind of my inspiration for, from a military standpoint, and then from a medical standpoint, it really comes from my family. I had a brother who was an Air Force ROTC while I was in high school, and I thought, the place I wanted to go to was the Air Force Academy. My eyes quickly told me that I wasn't going to be an acceptable candidate out there, couldn't get a waiver. And so I really shifted my focus into getting into West Point, which really, in terms of my military medical career, I thought was the best fit for me. And then secondly, I think the real inspiration for me to go into medicine was my sister, who is a pediatrician, and also her husband, who is an adult cardiologist. Always looked up to them, always respected, how smart they were, the things that they did in their careers, and just wanted to follow along in those footsteps. So I think those two combined, those two siblings of mine, really probably started me on that pathway.
So after USUS, you trained in pediatric hematology and oncology. Was there a specific moment or an influence that solidified that particular decision for you?
Yeah, like I said, I probably got drawn into pediatrics as a specialty, primarily, through my sister, but then, and thought about something like pediatric oncology, which as a med student, seemed like a very daunting thing to pursue. But when I went out to Tripler for my residency, where I just received, I think, the absolute best training that I could have gotten as a Army pediatrician, the people that I got trained by, when I was there, like probably what happens for a lot of physicians, a lot of military physicians, there was a mentor, there was a staff in the department that, literally took me under their wing, took me on rounds as an oncologist. And that really is probably what inspired me to think that I could do that as well. And so things that really drew me to oncology, oncology care tends to be very ordered when it comes to delivering chemotherapy. I enjoyed the regimen nature of protocols of chemotherapy, knowing kind of the exacting way of delivering care. And that's in some respects what drew me to it, but really what inspired me more so were the patients, getting to know the patients, getting to know the patients' families. And that's really what kept me engaged in such a challenging field.
Now, is there a particular patient case or moment from your clinical years perhaps as a pediatrician or as a hemonc specialist that really left a lasting impact on you? And can you share that story and explain how it influenced your perspective on military medicine?
One story that would really inspired me as a pediatric oncologist was the first patient that I had in my fellowship. Was a young girl, blonde-headed 2-year-old with the same name as my blonde-headed 3-year-old daughter. And I had two daughters at the time. Our son was just a newborn. And here I had this brand new patient with acute leukemia who, for all intents and purposes, looked like my two daughters. And it really hit home in terms of just who I was caring for and the responsibility that I had as a pediatric oncologist. I've always, remembered that to this day. And then I think from an operational standpoint, in 2003, when I deployed early in the conflict, and there was this period of time where things were relatively quiet in Iraq. That's where I deployed to, where we had begun to do some outreach into area hospitals to look at capabilities that they had. This is really pre-insurgency. We came into a hospital. They took us into what amounted to be a pediatric ward. It was really a med surge type of ward. And there was a young child there with obvious bruising, very pale. Somehow they, through the interpreter, found out that I was a hematologist oncologist and did some examination on the child and had no laboratory data, but, it was likely that the child had pretty advanced leukemia or possibly aplastic anemia. And I tried my best to explain, potentially what they would need for treatment. But it was sobering because it was a very poor, medically fragile type of situation. And I never was able to follow up and find out whether or not they were able to get that care. So it was just an example of, in the midst of this conflict going on in a country, mothers and fathers are trying their best to take care of their children. Children there suffering from the same diseases that children in the United States suffer from. And it was just a reminder of our call as physicians, to ease suffering as much as we possibly can.
Yeah, it's always nice to have that reminder of humanity, and it's basically the same all over the globe, and you see those challenges, and that's one of the things that was frustrating for me too, is not being able to follow up on some of the cases that we saw while deployed. We have a pretty good amount of younger folks that listen to the podcast, and they like hearing from the gray hairs every once in a while. Can you share a challenging situation that you faced early in your military medical career and how you overcame it, and what key lessons that you took away from that experience?
Probably a couple that come to mind. One is, I came out of my fellowship. I was able to do a 6-month postdoc after my fellowship in pediatric bone marrow transplant, because at the time I knew I was going to San Antonio and we still did PD BMT there. This was really 2000, end of 2002, so things had started to change. So I PCSed a little bit off cycle in January, and as soon as I got there, I got tapped on the shoulder to deploy. And something that you just don't really know kind of what to expect. And this was, of course, early on when we were deploying large number of medical forces, the old PROFIS system, which we really had not done probably in close to 20 years during the Gulf War. That was challenging, probably on a very personal level, for our family, having moved. And then all of a sudden, a month later, I'm at Fort Cavazos, Fort Hood, and then out the door with 4th Infantry Division. I think the way that I handled that was, you just sort of take one step in front of the other, and you try not to be too intimidated about the prospects of going overseas. You truly, try to understand who your people are that you're going to be working with, try to get to know them, embrace being part of the unit. Don't consider yourself to be, the doc who works down at BAMC and he's just up here just to, just to deploy, but you really have to say, I'm part of this unit. I'm wearing that patch now, and embrace that. I think that was probably early on, a challenging situation. And personally, I think one of the other big challenges was during my fellowship, I was actually diagnosed with Graves' disease, and that was particularly challenging because of some of the behavioral health or just mental recall that occurs that can be seen in Graves' disease. I struggled with my confidence that I could, complete my fellowship because I quite frankly had difficulty with my short-term memory until I got my thyroid fixed. So, all the worries that go along with that, and then just the confidence and the reassurance that I had from my fellowship director, Dr. Gary Crouch, a great Air Force pediatric hematologist oncologist who just reassured me that everything was going to be fine and got me through that during that rough patch.
Yeah, your career, you've transitioned across many diverse roles from being a clinical leader at Brian Allgood Army Community Hospital in Korea, advising medical readiness at the Office of the Army Surgeon General, advising the command of training and doctrine command. Can you tell us about a time when you had to adapt to a particularly demanding new role or environment, and how did you handle it, and what did you learn from that?
So I would say two things. I think that one of the biggest challenges that physicians face when they're put into a position of leadership is what that transition looks like to go from direct patient care to now managing an organization. So for me, the biggest leap in the challenge was presented was the time that I went from Triple Army Medical Center, where I was the chief of the pediatric oncology service, to going up to Madigan Army Medical Center to be the chief of pediatrics. And I think people say or know that we don't do a great job. I think we're doing a better job of leader developing people. But to be put into a situation where all of a sudden I was managing a budget, managing a large residency program, pediatric subspecialty clinic, primary care clinic, which I hadn't done for a few years, and then managing civilian personnel, and all of a sudden you're dealing with potentially the professional issues that sometimes face physicians. Your staff is looking to you to provide support, to provide vision, and real guidance of where the department needs to go. And there were some particular challenges at the time. There was a lot of transition in primary care in terms of expectations for that. And quite frankly, I think I was underprepared for the position. And I think that was the biggest change in terms of going from direct patient care, it's you, the nurse, the patient, their family, in case of pediatrics, to now all of a sudden a much more operational base. And I found that challenging to make that adaptation the first couple of years that I was in that role. Secondly, when I went to Office of the Surgeon General, as a pediatrician, my only real awareness of medical readiness was getting my PHA done every year, right? Making sure I go get my dental and get my vision and all the labs. And now I was the Surgeon General's representative for retention standards, accession standards. And that was an area of, military medicine that I was just not familiar with. I think in that case, I learned enough that I told my team, quite frankly, I'm not going to be the best at this. You all have been the subject matter experts for this type of work, for this type of policy for a number of years. I'm going to rely on you. I will get us where we need to go in terms of changes for those policies, but really just admitted and embraced my staff that their expertise was what I was going to rely on for us to be successful as a team.
So your current role is commander of the U.S. Army Medical Research Institute of Infectious Diseases. And the last time we talked, you told me a funny story about what your kids and neighbors think you do
Yeah.
and how that might be a little bit different from the actual mission of USAMRIID.
Well, USAMRIID is an amazing place. It's been the best job that I've had in the Army. I love our staff. I love our mission. But as you can probably imagine, there's a lot of misunderstanding about the work that we do because it is biodefense. It's not, we don't execute top secret work, but we do it behind kind of a little bit of a wall or a veil, if you will, from the standpoint that, we work in a biocontainment space. So there was some cartoon that there was a picture of a bio lab. And so I remember that from a cartoon that I was watching with the kids. And then there's a number of movies, that have USAMRIID or a caricature of USAMRIID. I think, in terms of Hot Zone and other ones that have come out that, represent what USAMRIID does. I don't know if it's quite as cool. I think one of the commanders in one of the movies was Dustin Hoffman, which that's cool, but that's not me. No, so there's some, I think, a lot of misunderstanding about our work, but again, it's such an amazing place, and the challenges that we've dealt with and that we continue to work on has really been inspiring for me as the commander.
Can you share a story from your time as commander that really illustrates what the USAMRIID mission does to protect both military and the public from biological threats?
One of our major missions is that we provide combatant command support, direct support to the combatant commands. And over the past year, on one particular, really two particular occasions, we received samples from a combatant command to do some very detailed testing. Some of these were human samples that we were looking for particular pathogens. And then another time it was a material sample that we were asked to clear for any sort of contamination prior to it going through a more detailed analysis from an intel perspective. And so it's that type of reach back capability that we try to ensure that the combatant commands, command surgeons are aware of, that they can reach out to us 24/7. We can have a sample, human sample or some other type of sample taken into the biocontainment space. And if there is something bacterial or viral in nature, we can very quickly have an answer for the combatant commands within 24 to 48 hours of what that pathogen is. And then here in the national capital area, our reputation is well known. So we are part of what's called the Lab Response Network, which is a system that exists in both CONUS, national and actually international health systems, where samples that are provided from an individual who has an unknown fever or unknown constellation of symptoms, that sample can come to us and we can again take that into the biocontainment space, take it into our special pathogens lab and do the testing on it to make a determination. So a couple of area hospitals have asked us to do that type of work for them over the past year, which we're more than happy to be part of that type of response.
So you mentioned that USAMRIID conducts research on highly hazardous pathogens in biosafety level 4 facilities. What type of research, such as vaccine diagnostic developments, are currently underway, and how do they affect the emerging diseases like Ebola, hantavirus that we've seen in the news not super recently, but not too long ago?
I would say we have a specific way that we view pathogen work. So there is a surveillance piece, which is kind of the top line. So that's a lot of biosurveillance work, samples that can be done. And then there is a diagnostic piece that's sort of in the middle. So how do you then develop an animal model? How do you develop the genetic testing, the molecular biology testing for a particular pathogen? And then ultimately, our real goal is to develop all of that work then points to being able to develop a countermeasure. That countermeasure can either be a diagnostic countermeasure, or it can actually, or it can be what you mentioned, a vaccine, a monoclonal antibody, small molecule. And so across the wide range of pathogens that are considered to be biodefense threats, if you sort of put them on a grid and look at them and say, where are the holes in this grid in terms of those things that I mentioned? That's where we focus our work. And much of that work is focused through provided to us in conjunction with the Defense Threat Reduction Agency, the Joint Program Evaluation Office for CBRN. And all of those entities have a relationship with the Chem Biodefense program that's run out of at the DoD level. In terms of our current work, it ranges across a wide swath of pathogens. Primarily, we do a tremendous amount of viral work. The viral encephalitis viruses, pathogens, we do a lot of work in that area. And then also we leaned forward on mpox, monkeypox when it presented itself, especially those different clades that were considered to be more pathogenic and potentially at higher risk, but not ever forgetting, our ability to respond to, particular bacterial pathogens. In terms of some of the work, I think where we're focused, I would, mention our diagnostic systems division and our DSD. They're the division that does our work primarily in our special pathogens lab and in that lab response network. Where they're leaning forward heavily on is trying to develop those fielding capabilities that allow us to detect pathogens at the point of injury or at the point of where symptoms present themselves. And so being able to take that type of genetic capability far forward into a small device that you put into the hands of a combat medic or a level 1, level 2 type of facility is the type of work that we are focused on. So all of our divisions, our virology division, our bacteriology division, our molecular biology division, they all provide that type of material and that type of diagnostic fingerprint, if you will. And then our DSD, they take that information and turn it into fielding capability. And so that's where we're really one of the big focuses of our work right now.
So can you explain a little bit more of how biodefense really intersects with medical care? I understand you want to do things to prevent stuff. You want to be able to
Yeah.
detect it. You want to be able to prevent it. But once it happens, how much is USAMRIID involved in the treatment part or the medical part in biological warfare?
Biothreats they can mimic, a lot of other, a lot of other types of diseases. They're threats that we probably studied in medical school. And unless you're an infectious disease doc, a parasitologist, a virologist, you may not remember those types of, disease pathogens. A service member who's affected they're not going to come into an aid station and say, I think I was just hit with a bioweapon. They're going to come in with fever. They're going to come in with a constellation of symptoms that are suggestive of a pathogen. And then it really becomes a matter of being able to make that diagnostic decision early on. And I think, as we look at large scale combat operations, delayed ability to evacuate, prolonged field care, some of the things in Army medicine, military medicine that we're working on, the last thing we want to do is to put somebody into the evacuation chain who is a potential infectious threat to others in that chain of connectivity of care. And so being able to push forward the diagnostic tools as much as we can, that's certainly one of the areas that we see the benefit of providing this farther forward. And then in terms of treatments, these, one of the ways that I explain some of the work that we do is that that we focus on pathogens that are an inch wide but a mile deep. And so they're highly pathogenic in terms of the disease constellation, but fortunately they're not widespread. And so it's a challenge then to then work with industry to find countermeasures that are specific to a particular virus or particular bacteria. So one area that we've started to focus on is trying to repurpose FDA approved medications, antivirals, antibacterials that are also effective against these potential weaponized pathogens. And so that is some of the focus of our work inside the containment space.
So I'm going to assume that your office is not in the BSL-4 part of the facility, but I suspect that you've been there. Can you describe for our audience what it actually takes to get you from outside to inside the BSL level 4, and what kind of things do you have to worry about to keep people safe in that environment?
Yeah, it's a great question. I'll tell you, this is probably one of the areas where I find the most inspiration from our staff, because there are people who literally go into that containment space 5 days a week to do laboratory work. And so BSL-4, which is that highest level of containment, and this is probably what you see most on some depiction of that in Hollywood, is a space in which individuals are they go through kind of a standard locker room, changing room. They put on their equipment, which is consists of what is more or less a type of Teflon-like material suit that has booties that are taped up or part of the suit itself, double glove, taped gloves, and then the air that is supplied to that suit comes from HEPA filtered air hoses that are positioned around the room. And so they're always connected to that, and they conduct that work. One of the things that they have to do is when they first put on that suit, they have to test it to ensure there's no small type of pinhole that's developed in their suit that would, violate the integrity of the suit. So they go through that verification process. They do that with a partner who's, kind of a buddy check, going in and out of the containment space. And then when they're in that space, then it's very regimented in terms of the work that they do to ensure that if there's any type of spill, that the way that we manage that is very specific, and also in terms of reporting that. Then when they come out of the space, then they have to go through a series of decontamination, and that means doffing their suit. It always means a specialized shower for a certain period of time for them to ensure that that they are safe when they come out of that space. All of our personnel are enrolled in a program that highly monitors, their health in terms of whether or not they're safe to go into that space during that time. And our staff, if they get a cold or if they have some other type of illness, they self-report, and they're withheld until those symptoms resolve. In terms of the facility, that's probably one of the biggest areas that we are focused on in terms of safety, because, we're part of our community here at Fort Dietrich, and we have to ensure that the work that we do is completely safe. And so if, for the physicians and others who are listening, if you think about what a negative pressure room is in a hospital for somebody who has a particular infection, it's that air is being pushed into the containment space. It's always kept relatively negative to the space outside of it, so that if there was ever a release into the local atmosphere inside of the room, it's drawn into the room and not pushed out of the room. And then there's HEPA filters that filters all of the air. Any waste that leaves the biocontainment space goes through a specialized processing. Essentially, any liquid waste is cooked, if you will, up to about 200 degrees Fahrenheit, and then cooled before it's allowed to enter into the wastewater treatment system. But the walls and the windows of that space are at a prescribed thickness, because maintaining that constant air pressure puts a certain amount of stress on the facility. And so we have to monitor that very closely. Any variation from that is always reported as a finding. Fortunately, we have not had any significant mishaps or accidents that have occurred. And our staff does an amazing job. Our safety staff do an amazing job of ensuring that people are well trained to go into that space safely.
How do the labs in foreign countries compare to what we have at Fort Dietrich? And let's say we need to get one of these pathogens that we're finding in Africa or somewhere else back to Fort Dietrich. What goes into the planning of getting something that's highly contagious and pathogenic, on an airplane or a ship, or how do you get it there?
So USAMRIID, we are very much a kind of a standalone facility. The outlying Army medical labs are primarily aligned under the Walter Reed Army Institute of Research. Those that are in Thailand and other locations are primarily aligned from that standpoint. If we were to, need to get a pathogen sample, the most important thing is the packaging on it is done in a safe manner in which it's, very, contained in terms of how that gets shipped to us. And we have very specific guidance that we provide the combatant commands in terms of how to secure that effectively so that when it comes to us, it remains in type of containment so that the only time it ever gets open once it's been packed is once it goes into that containment space and the researcher, the scientist is in that highest level of protection posture before they would ever, expose any type of sample to, in terms of testing it.
So, as commander, what are some of the biggest challenges that USAMRIID faces, and how does the institute overcome whatever obstacles you find in your way?
I've been very fortunate to follow in the footsteps of a couple of great commanders that preceded me. Now Major General Darren Cox, Colonel Connie Jenkins preceded me in command. And the two of them did an amazing job in terms of reorganizing the command, and then also really working very hard to make sure that the research that we've been tasked to do, that we're executing it. We work on a model of research in which, a lot of our funding comes to us from the Defense Threat Reduction Agency for specific programs or specific projects that we then execute. And so, the challenge, like anyone, in the federal system, in the Department of Defense, is the fiscal pressure that may exist in terms of whether or not those programs can maintain their viability, but also, I think more importantly, the relevancy of that work to make sure that we're executing research for the purpose of meeting a gap in a capability that is out there and not necessarily just for research sake. Now, we do a fair amount of basic science research, so it may not be something that's seen, in terms of fielding, but all of that work builds from one to another in order for us to have that fielding capability. So I think that's probably, the biggest challenge that we faces that, we're seen as a reach back capability, that we have to be able to maintain. So we always have to keep things warm, if you will. But we're also a research organization that is dependent on bringing in funds in order to fund the research. So we have to marry those two things up in order to maintain those capabilities. And like anyone, we're in competition for great people, right? So we need smart microbiologists, we need smart virologists, molecular biologists to come and work for us. And so I think we offer a unique mission set that is like unlike any other in the world. So I think that's a big draw for us. But again, always a challenge, right, to get people to come and to work with you. I will say that I think one of the most enjoyable and inspirational things is that it's not just my uniform staff who want to go out and test our equipment and our capability. It's our civilian staff. Our PhD civilians go all over the world collecting samples, taking our equipment to the Arctic Circle, to the desert, on experimentation days with Army Futures Command and others in order to test and see whether or not this equipment stands up to the rigors of being functional in the operational environment.
So you mentioned the people that work there. What is the breakdown of civilians to active duty? And if someone's listening to this and says, "Man, this sounds like a really cool place to work," what kind of steps do they take to take the next step to try and get there?
So our uniform personnel are virtually all Army, and so we have a number of folks in the 71 series, microbiologists, biochemists. That forms our active duty personnel primarily in from a science standpoint, but also our vet corps officers, our veterinary corps officers, our 64 Charlies, our 64 Deltas. These are our lab animal specialists and our vet pathologists, which as physicians, the medical corps and the vet corps, we don't hang out a lot together per se, unless you're out maybe in an operational unit or a special operations unit. So that has been probably one of the most refreshing and enjoyable things to get to know and work with a number of our veterinary corps officers who just do great work in terms of our animal husbandry requirements, our pathology requirements. They are really the backbone of us finding many of those types of the answers that we're looking for in terms of those in vivo studies that we do. And then you asked about our breakdown. So we have about 150 military personnel, and that's not just officers. That's a number of veterinary technicians, laboratory technicians, a few 68 whiskeys that are on our staff, and then some other in admin and other support that round out our military population. And that's somewhere between 150, 170, fluctuating from time to time. And then our civilian personnel are DoD employees, and they number about 200. And then we have approximately that in contract support personnel as well, across kind of a wide range of disciplines where we need that contracting capability. And so in terms of how do you get to USAMRIID, there's a number of different pathways. I think one of the coolest things, having been in command, is when I've had an opportunity to travel, is I have people come up to me and say, I got my start at USAMRIID. I was a lab tech at USAMRIID. I was stationed there as USAMRIID right after I finished my master's degree. And people have gone on, gotten their PhDs and are running their own labs in many instances. So I think that's kind of been the amazing legacy that is the research that is done there. We have folks who get to us, for our laboratory officers. If they have a very strong PhD basic science research, often they'll do a utilization tour, usually in an MTF. Sometimes they'll be up at what used to be the first AML, the global medical lab that's up at Aberdeen. And they'll come to us, and then they'll get themselves into a lab and start to do work as a primary investigator. For our military personnel, I think they really have to sort of raise their hand and want to come to USAMRIID in order to be able to work in the laboratory space, in that research space. Our civilian personnel, we obviously advertise when we have openings for investigators, and then we also have a number of postdocs that come to us, or individuals have their bachelor's degree or their master's degrees. They come in under the wing of a primary investigator. They learn not only how to, hone their research skills, but also hone their research skills in the BSL space, so that they can go and work there safely. So it's an all comers opportunity that we have, that we really have a great team.
So, one of the public health emergencies that's not too far in the rearview mirror for people is COVID. Can you just share some insights of how USAMRIID contributed, how it worked, the federal side worked with civilian side, and what lessons were learned that we could guide future public health emergencies?
That's a compelling story, and it's really, I think, a testament to what it takes in terms of kind of an all-out government effort in order to combat a worldwide pandemic. Much of this was preceded me, right? I wasn't the commander there at the time, but I think if you look at in terms of result and output, virtually every vaccine, every medication, monoclonal antibody that has been approved and utilized to combat COVID, in its initial stages, had a touch point at USAMRIID. We received some of the earliest samples. If you remember, kind of the first major outbreak occurred up in Washington State at a nursing care type of facility. We were able to receive samples from them and then use those samples in order to produce enough of the virus and maintain its stability for us to then undertake the work that needed to be done in terms of starting to study the genetics, the molecular biology of COVID-19.
So, over the past 40 years, USAMRIID has achieved many milestones, like developing the anthrax vaccine. And I'll just admit that my gluteus is still sore, I think, from that vaccine injection. They also came up with a joint biological agent identification and detective system. What recent accomplishments are you most proud of in your tenure as a commander there?
Probably the thing that we've probably pushed the farthest forward is a capability we call Dragon Medic that utilizes some off-the-shelf technology to take sequencing as far forward as possible. And so I think that's an area where we have really shown our worth. We've done some field testing that is very promising. We've got, I think, strong endorsement from an operational standpoint that this is a capability that is needed, that again allows us to, we're not quite at the point what my team calls the holy grail of diagnostics, which is a completely agnostic system. In other words, we're not sure what we're looking for. We're going to put a sample in and the device is going to give us the answer. We're still at the point in time where we can give it a sequence of genetic code and say, look for this sequence. And it's able to look for it and find it and determine whether or not, that's what it's detecting in the sample. So it's that balance of trying to be able to all things to all people versus more targeted type of work, that is much of our focus. And that's one of the things that Dragon Medic is getting us to, kind of bridging the space between something that is completely agnostic and something that is so direct that it requires different type of testing kits. You have to have kit A to look for this, kit B to look for something different, kit C. Now we're at a point where we can push forward the sequencing and say, look for this sequence. And that's what the detection device is starting to be able to do for us.
So you've been associated with military medicine for over 30 years. We've got some young folks listening, like we mentioned. How would you describe your why? Why do you wake up in the morning and put your uniform on and want to go to work in military medicine? What is it about military medicine that people should say, hey, I could consider this?
I think I've had a few different whys over my career, and I will just say, and I'm going to retire, post command a few months after I come out of command, and so I'm, right at the point where I'm, 29 plus years of service, and so, there's not much time left, if you will, before I have to hang up my uniform. But I will say early on, my why it was all about the patients, and it was all about being the best physician that I could be. And I think that the training and the opportunities that are presented inside the military health system are unlike any other. Blessed to come out of undergrad and medical school with zero debt, and then being able to focus, all of my energy on, professional energy on being the best physician that I could possibly be. So early on, it was all about the why was taking care of the patients. Probably, about 10 years into my clinical career, I had an experience where I started to see that maybe some lack of attention from, I guess, a leadership or a management standpoint started to have impact on clinical capability. In other words, what we had was a multi-specialty lab or multi-specialty clinic that was staffed. It was well organized. It was well run, but the capabilities and the resources started to be chipped away, and all of a sudden, what we could do started to diminish. And that was the first time that I thought, maybe one of the things that I'm called to do in my career is to try to set conditions for clinical success. That's how I phrased it. How do you get the resourcing in the right place at the right time so that, the clinicians, the nurses, the technicians, the front desk staff can always be pointed towards taking care of the patient the best way that they possibly can. So first part of my career was, me and the patient, me and, my nursing staff and, the mom and dad and so forth. That was my why. And then over the past 15 years, it really transitioned into my why became, how can this organization be successful in terms of ensuring that what we're doing from a clinical standpoint is safe, it's reliable, and it meets the needs of the people that trust us with their care.
So when the history books are written 50, 100 years from now, how would you want your great grandkids and their kids to read about your legacy in military medicine?
I would hope that people would know that I cared, that I cared about what was going on within, if my patients remember me, that they remembered that I cared about them, that I took, efforts to really get to know them and explain to them what was going on with them and what was going on with their children. I think that's probably the most important thing. Even as the most successful, probably hospital commander would still say, yeah, this is great, but I don't know if this compares to like really helping somebody from a medical standpoint. I would also, hope that people would see me that I've been a team player and that I know that, military healthcare, it requires so many people with such diverse capabilities in order for the system to be successful. A lot of people have come up to me both in uniform and out of uniform and said, why do we have pediatric hematologists, oncologists in the military? So much so that sometimes you start wondering, well, yeah, that's a good question. Maybe I don't know why. I don't know. Maybe we shouldn't. But the reality is that when pediatricians, have gone down range, they have taken care of service members very, very well. And I am proud that I am part of that legacy. I think you spoke with a good friend of mine, Phil Spinella, Dr. Phil Spinella, pediatric intensivist who has done tremendous work, in his role, as a civilian to advance some of the things that he was working on while he was in uniform. So I think that's what I would want people to remember me for. Hopefully the staff at Fort Leonard Wood, while I was the commander there, and the staff at USAMRIID will remember that I tried to set them up for success, in spite of some of the challenges that we faced in both of those commands.
We've been speaking with Colonel Aaron Pitney on WarDocs podcast. Aaron, thanks again for sharing your experiences and insights with us. And thank you for your service to your nation and the best to you after retirement. Well deserved.
Thanks so much, Doug. It's really been a pleasure to speak with you tonight.
Thank you for listening to WarDocs. We sure hope you enjoyed it. WarDocs is a nonprofit organization supported by donations from listeners like you. Please follow and subscribe to our show on whatever platform you consume your podcasts, and rate and review this episode, and share the show with your contacts on social media. Find out more information about our show, our guests, and how to become a member of Team WarDocs on wardocspodcast.com. Thank you for your support. If you like war stories and medical drama, WarDocs has you covered. Spread the word.